An important and perhaps unexpected lesson learned during the COVID-19 pandemic was that the lack of trust in the public health system generated significant barriers to disease containment efforts and vaccine uptake. I didn't know that we could have foreseen that vaccine promotion would consume nearly as many resources as vaccine development. The Lancet recently published an article that explored contextual factors associated with COVID-19 infection and fatality rates in 177 countries. Headlines from the popular media reporting of the study are presented in the middle of the screen. Quoting from the paper abstract, efforts to improve pandemic preparedness and response for the next pandemic might benefit from greater investment in risk communication and community engagement strategies to boost the confidence that individuals have in public health guidance. So, who's a trusted source of health information and is effective at community engagement and is poised to inform health promotion strategies and future pandemic response? The answer continues to be community health workers. CHWs are a critical component of the healthcare workforce. According to the American Public Health Association, a community health worker is a frontline public health worker who is a trusted member of and/or has unusually close understanding of the community served. The Rural Health Information Hub states that CHWs often share life experience with the population they serve, such as ethnicity, socioeconomic status, language, or medical condition. While CHWs have traditionally worked with racial and ethnic minority populations, in recent years, they have begun to serve a wider variety of rural, urban, and underserved populations. The COVID-19 pandemic generated substantial resource investment in expanding the CHW workforce. Unfortunately, we lack adequate numbers of CHWs in the healthcare workforce, and we have sustainability issues related to reimbursement for CHW services. The map on the left shows CHWs by location quotient, a statistic that measures a state's CHW workforce relative to the nation. An LQ less than 1 means the state is less saturated than the national average, while an LQ greater than 1 means that the state has a higher concentration of CHWs than the nation. Based on this metric, states in dark red have relatively high concentrations of CHWs, while states in tan or pink have relatively low concentrations. The map on the right shows CHW Medicaid reimbursement by state. About half the states offer no Medicaid reimbursement for CHW services, limiting their ability to work with the most vulnerable populations. There is, however, some good news. The federal government recognizes the value of CHWs and earlier this year dedicated well over $200 million to fund CHW training programs across the country. Those programs are scheduled to begin this fall. So, lack of trust in the public health system remains an issue. CHWs are critical to bridging the gap between healthcare systems and communities. CHWs have a comprehensive list of core competencies, and I'm humbled by their work expectations. CHWs are as important to urban underserved populations as they are to rural populations. There are, however, greater training challenges for rural-based CHWs. There's limited access to in-person training, and broadband access can be inconsistent. Effective use of CHWs will require robust continuing education that can be disseminated quickly when needed. A recent example is the need to rapidly disseminate information on monkeypox. I leave you with the following question to explore during this UnConference. Given that telementoring is an effective training strategy, how can telementoring be effectively used for CHW workforce development?